Your poster at the FIP Congress was about designing a pharmacogenomic testing service for community pharmacy. Could you just walk us through this and explain why you adopted this approach?
Yeah, so as I said, the MRC guidance says that you need to get your stakeholders together, you need to listen to them and put the idea to them and then sort of co-design, co-create. Now, what I have to say about that poster is it was led by Tim Rendell, who's the head of pharmacy for Day Lewis Pharmacy. So I was his PhD supervisor for the project and with a number of others as well. But what he did, he got some pharmacists, some patients and GPs into different rooms to talk through the idea. And then to say, so what are your initial thoughts? And then, if we're going to deliver this, how should we deliver it? And there was no sort of disagreement that it shouldn't be done by community pharmacists. So the GPs were pretty relaxed about the idea. They would like that. All of them said, well, the pharmacists and doctors said, we've had little training. It was so long since I last did anything to do with DNA or understanding this. This is new technology. So there was a reservation about the technology and not knowing the science. But then actually there was clear, they recognized the benefits when they realized that this would mean that patients didn't come back so often because they were given the right drug the first time and they were less likely to suffer side effects. They could see some real benefits to it. What they didn't pick up on, and probably we should have discussed a bit more, is the fact that you do need to test 5 patients to get one positive result or one that needs change, and that's where the workload comes in with it. But there was clear positivity about the idea and the technology, and also about the community pharmacists doing it. But understandably, the community pharmacist concerns were about time, space, the appropriateness of their consultation rooms for doing DNA testing. But actually, it's simpler than a COVID test. It is a simple swab inside the cheek. Patients can do it themselves, and very often that's the model anyway. And so you don't need that, but you do need to sit down with the patient and talk to them about what this means, what's going to happen to their DNA, what's not going to happen to the DNA, more importantly, and reassure them what the result means. So if the result says, actually, this drug's okay for you, that's fine. But on the result, there's also another 50 medicines which they may take in the future. So they need to be aware of the fact that some other medicines, and very likely some other medicines, may not be appropriate for them according to the BNF or according to the guidelines. And therefore, they need to be aware of the fact that when a doctor starts anything again in the future, they go back and check that result before they start something, because it gives you information for life. And one of the things that happened in another country, I found that doctors were ordering the test more than once for the same patient. Your DNA doesn't change. And that, again, shows people's lack of understanding of the technology. And there is a barrier there that we need to overcome to train them. But he had very good positive focus groups. People were very honest about their concerns. Obviously, the other concern is about where do we store the data? How do we make sure the data is presented in a way that I can understand it and use it? And again, only when you've used it and tested it and trialed it, can you then get that confidence in the system. And again, one of the sensible recommendations was a soft start. Let's not just roll it out for everybody. Let's do it small scale first time, which is what I always do as a researcher anyway. So people then know what they're doing, can answer any questions. We can change the system if we need to, but then before we actually roll it out big time.
That's interesting. And how will the findings from this project influence what happens in practice?
What it's done very nicely is helped us design a training package. So we've tried to design one for community pharmacists to help them implement the service. And what was very clear from it is they need to work with the doctor. This, as I've said before, this cannot be on the side. This needs to have a proper setup meeting, whether it's the LPC or the LMC, or whether it's the community pharmacists with their local GPs. Whatever happens, before you set this up, you've got to sit down and agree how you're going to communicate, agree what patients you do, and make sure you're both confident in responding to the information when you get it. So what we have learned is we don't need to teach the science. We don't need to go down to the detailed level. What we need to do is make sure they know how to respond to it and to treat the patient, not the result. And that's very clear to me. It's kind of, look at the patient. Are they okay? And if the result says something else, treat the patient. Don't follow the result, because actually the thing with pharmacogenomics is it's based on observational data, not trials. And so again, it's a bit like everything else we do. It's 80% correct, but 20% it won't be. It's a bit like when we look at interactions. Some people have an interaction, some people won't. It's the same with pharmacogenomics. It's not perfect. And therefore, we have to look at the patient, look at how they're responding, then look at the result, and then make a decision, but not treat the patient due to the result. So, yeah, but that was really helpful. And the training, as I say, is about giving them the confidence to offer the test, the confidence to respond appropriately to it. It's not about them needing to understand exactly which base pairs in the DNA are different and why those base pairs have caused this change in metabolism further down the route. Unfortunately, a lot of the training is focused on that. And what was interesting, I went to the Netherlands to see how it was running in a community pharmacy. And the pharmacist said to me, "So yeah, we do a year of hard science of pharmacogenomics." He said, "But I haven't got a clue how to give advice. That wasn't part of the training." And he said, "So actually, because I don't feel that confident in the topic, although I've had all that science training, I don't feel that confident. I'm probably not as offering it to many patients as possibly I could do." And it's all about confidence. It's all about demystifying the very clever, very complex science for the healthcare professional and for the patient, so that we make the right sort of decisions and we don't worry about what's underpinning it.